Yeah. So for those of you who attended last year, I talked about some of our methods for anthrax, how we detected different toxins, and then I went through some of the clinical cases that we've been seeing routinely. But this year, I thought that I would expand on that and not talk about the methods or anything, but mainly talk about how we're using the toxin levels to predict antimicrobial and antitoxin treatment efficacy, and basically make a long story short is if the toxin levels go too high, you've been poisoned, and even though if you kill the bacteria off, you're still poisoned. So it's basically the concept. I want to say this is actually some of the animal studies we did more as a team effort. My lab actually did the analysis, but we worked very closely with the special pathogen branch, Alec Hoffmaster and his whole team that are over there. Also, Conrad Quinn, for those that do Anthrax, probably know his name. And then the animal studies were planned and financed by BARDA, and that was John Lee and his group. And also, then they were done at Patel, all the anthrax exposure, and that was Dan Stanford and his team. So, going on, I'll start with a quick background on the toxins. I think this probably can be really short because this group probably knows about that. Then anthrax toxemia in uh, non-human primate models, and then treatment with Cipro in cynomolgus. That's also the crab-eating macaque, and I'll probably just call them cynos throughout the talk. Comparison of the toxin levels in non-human primates and New Zealand white rabbits, animal models, and then finally antitoxin treatment efficacy in the New Zealand white uh, animals. So there's 5 forms of anthrax, and the first one, cutaneous, had about a 20% death rate if it's untreated, but only about 1%. Right now, we're dealing with well, this is almost yearly with getting samples from Bangladesh. They have outbreaks every summer. It's just so endemic there, but also in Haiti, there's a large outbreak right now. The information we're getting is cutaneous, but I think there's some of them that are mixed, maybe cutaneous and inhalation because toxin levels were really high. There's gastrointestinal, and we've only seen 3 cases of that in the U.S., but it's kind of bad because usually they have some kind of immune compromise. I think the last one we did, the woman put a sandwich down on a drum at a drumming contest and then finished eating it, and the drum had the animal skins had anthrax spores in it, and she had hookworm, and so in the area that had hookworm, it actually was able to grow because of the compromised immune system. Inhalation, that's what we see very rarely in the U.S., but it's really bad when we do. Most of the cases have been from people who imported, put that in quotes, skins from Africa, and then made drums out of them. That we did have one fellow that was out digging for gems out west and got it that way. But this had a really high. If you don't get treated, it's a really high. Even with treatment, it can be really high. So the last incident was in the Soviet Union, and it was a weapons plant that was making anthrax. And the guy took the filter off, and then realized it was quitting time, and so he wrote a quick note, said, don't turn the dryers on," and he left. And then the next guy came in and said, "Why aren't the dryers on?" And he turned them on. He didn't see the note, and it blew the spores basically into the little village that had workers there that supported the weapons plant, and so they had a huge number that died. And then they didn't get the truth. It was like, "Oh, we think there's contaminated meat. Take these antibiotics," but it wasn't. It wasn't. Yeah. But even in the U.S., anthrax letter attacks in 2001, almost half the people died. Even, that was with antibiotics and really high level of supportive care. So it just kind of shows that it is an anti-disease injection. You probably got it from the UK, know this better than we do in the US. Glasgow and that huge outbreak, a little bit in Germany and some other places, but Glasgow was really the center. And then again, it was people that did the heroin in their arm. That showed up faster because people could see it. The ones that shot in their groin were often the ones that ended up dying in that. And then in the U.S., we've been seeing a few welders' anthrax cases, and this is like an anthrax-like disease. It's from Bacillus tropicus or Bacillus cereus that picked up the PX01 plasma, and for some reason, only welders get it. We're trying to figure that out, but it's just kind of interesting. But this has been showing up again on the Gulf Coast of the U.S. Haven't been many cases, but almost all of them died. So, and then, if you look at the diseases, and I'm going to be real quick on that, there's 3 different levels that have been described in the literature. There's kind of this early prodromal, where patients become rapidly ill. This intermediate progressive, where they continue some. Some patients actually they think are improving and getting better. But then you go in the late filament, and that's where patients relapse, then get rapidly sick and die within, usually a day or two from that point. So, with that description, we actually can quantify lethal factor, and that's a zinc protease that disrupts cell signaling by cleaving a MAP kinase. So we can't put a kinase on a MAP kinase, and that's important for cell signaling. Then there's also edema factor, and that's an adenylene cyclase. So it takes ATP and very quickly makes a ton of cyclic AMP. And then that causes cells to be leaky. And most patients that die from anthrax actually kind of bleed out. And so that's actually can be one of the causes of that. And then there's protective antigen. That's actually the one that binds the receptors on the cell surface and makes a pore in order for the protease or the adenylene cyclase to get in. So they're all expressed differently. And then the PA83 has to be cleaved to be a PA63. So what we've done is we've come up with methods using antibodies and activity. So if you use a lethal factor antibody, you get this and this. If you use an edema factor antibody, you use this and this. If you use a protective antigen one, you get this, this, and this. But then if you look for the lethal factor in that with that antibody that we do for the activity by mass spectrometry, then you can know you have lethal toxin or toxin. So you can separate totals from how much is this in the toxin form. And that's what I talked about a lot last year, so I won't go through that. But the mechanism is basically either in the serum or in the cell surface. This shows Lepla showed it on the cell surface. So it does have a furan cleavage site. It has an RKKR in it, and so everyone thinks furan, but I think it's more serum proteases that are doing it. But anyway, once you have that and it cleaves off that 20, that's when it can then form either a heptamer or an octamer, which then binds EF or LF, and that gets into the cell. And then basically it does this enzymatic activity. EF requires commodulin. It grabs it and uses that actually calcium to do the reaction. So I won't go into great detail on that, but basically what our detection limits are. And this is, I'm an organic chemist, but I've become an analytical chemist throughout the years. Detection limits are important. So when you see something show up early in an infection, if you have a lower detection limit, well, maybe that's why you're seeing it. One that has a higher detection limit, you just start seeing. And that's the case here, I think. LF, we always see first. That's 2.7 picograms per mil, whereas protective antigen is 1.2 nanograms per mil. And so we often see LF before, or LTX, which has PA on it too, before we see protective antigen itself. And then the edema factor has a really low, that's 19 femtograms per mil. So it's lower, but we actually see this coming usually later and in real small amounts. And they're pre-symptomatic. So looking at animal studies, and this was done with cynos, I believe, that we see where the blue and gray go, that's where you see symptoms. And it's the LF always shows up basically first. And then the PA will show up either at the same time I mean the EF or slightly after, but then you see the PA a little bit later. But again, I think that's probably because detection limits are higher on that. And we often see this triphasic um, progression where you have the phase 1, they get sick, phase 2, they start feeling a little bit better, and then phase 3, it goes up rapidly, and they end up dying. What's interesting is all this one is, the red one here is LF, and the orange one is LTX. And at the end of the infection, basically all the LF is in the lethal toxin form. The same thing we see actually with EF now, which kind of goes below, but if we had ETX, it would come up the same thing. And then protective antigen is always the highest amount, but because of detection limits, we can't see it earlier. So, other thing that was interesting that we found, we actually were hoping that you could distinguish what stage of anthrax you had by the PA83, PA63 ratio. But as you can see, it actually gets processed very quickly, probably in the serum, and all the way through. There's hardly any PA83. It's all been processed and processed very quickly. It's just when you're dumping out big amounts, it doesn't quite have time to get processed, but that didn't work particularly well. But it's interesting to see this. And then with the this one is Senos also. We see the same thing with rhesus, where about half of them are these fast progressors, go straight up, die before you can even treat them. And then the other half are kind of this triphasic that stretches out like this. And then at various times they go over kind of this one line, and that's when they're going from phase 2 to phase 3. So phase 2 levels are actually just about an order of magnitude difference. That's all. I mean, it's really pretty tight for non-human primates. But as you can imagine, for a human, you can treat these and they'll get better, but these are hard to, and they're about 45%, which is about what we see in the human anthrax cases in 2001. So basically, we see these 3 progressions. One that just shoots straight up, and the animals die. One that goes into a little triphasic, and the animal dies, and then this phase. What's kind of interesting, if you look at when they cross this line to when they die, here and here, they're almost the same. One is 21.3 hours and one is 21.4 hours, plus or minus 7 hours in both cases. And so it's kind of interesting is that you can be a slow progressor, but after you go over a certain point, the disease is what it is, yeah. And so this is actually treating with antibiotics. And this is a messy slide, but all I want to show on this is basically when it's treated early, you can go over the gray line. So this is the range where things start going up into, but you can go over the gray line, but not the red line. And only one animal didn't survive on that one. When you go to 48, then the ones that shot straight up are all already dead at 48 hours or soon after. And then the ones that are successful. So if you go over, the gray line or certainly the white line, then they don't survive. And then in 72, it's you have to stay pretty much below the gray line in order to have them survive. And then I'm going to point this out in another slide, that these ones where they die a little bit on the lower side are kind of interesting also. But this is the control there, which in all of them ended up dying in this study. So this is just a blow up in 48 hours. And you can see that, you can come right up to it and still survive. But if you go over, it certainly is not going to survive. This one, this orange one, was kind of interesting. It's almost like it survived to the last Cipro, but we've seen this before too. It's almost like there's a reservoir of spores somewhere that didn't get killed, and they're blaming the lymph nodes. Most of our colleagues over infectious diseases being probably where the spores are hanging out. And this one just shows that it basically all the toxins behave the same. They go over a certain point with protective antigen, lethal factor, which I already show you, or edema factor. They basically die, and then they go, because they're always pretty consistent ratios between these. When you look at the difference between animal models, so these are rhesus macaques, and again, you have the fast progressors and the slow progressors that are in a fairly narrow band. These are cynos, and I showed this data already, but a narrow band with fast and slow progressors. When we go to New Zealand whites, we have no fast progressors. Kind of interesting, but also the phase 2 levels are all over the place. Actually, it's harder to interpret New Zealand white data because I don't know, they don't follow the same pattern. And I think if we look at people, I think cynos are probably between people and white rabbits, kind of in how the progression goes. But as you can see that it's just harder with white rabbit because there is such a wide range. But we've done fair number of studies. White rabbits are a whole lot cheaper than a non-human primate. They're easier to take care of. There's less ethical problems. So a lot of the beings are, and they're about the same size as a little bit smaller, but about the same size as a rhesus. But anyway, just really quick. So I said the ones that died with lower serum levels all had meningitis, high levels in the brain, and we see this also in humans too. With the humans, there's only been 12 reported cases of meningitis. When anthrax goes into meningitis, have survived. We actually worked on one of them in Spain, where a guy was cleaning out a sheep farm and ended up getting it. But whereas, this is last patent was at 2,000, and this one's at 100. But brain is the main one. And I know I'm running over, so I'm just going to do this, and then I'm done. So basically, in the New Zealand white rabbits, we tested 3 antitoxins. This is a polyclonal one collected from people that were vaccinated, mainly soldiers. And then these are 2 monoclonal. And as you can see, this is the survivors that you had to have relatively low toxin levels to survive the polyclonal, and you could survive with higher toxin levels for that. But if the toxin levels been too high in all of them, then they don't survive. And that's basically all I'm going to say about that. Are there any questions?